Hello and welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. I'm your host for today, Jenna Morton. I'm preemie mom to twin boys who were born at 32 weeks and are now 11 years old. Preemie Chats is the creation of the Canadian Premature Babies Foundation, also known as CPBF, which you can see up there in the corner of your screen. And at the bottom, you can see our website, canadianpreemies.org. The foundation is a parent-led charity that helps families during and after their NICU time through education, support, and advocacy. I hope you'll take some time to visit the website if you haven't already. Again, canadianpreemies.org. You will find all kinds of resources there, links to our previous Preemie Chats, which we have 3 years worth of videos. You'll find our podcast, all kinds of resources. But most importantly, you'll be connected with a community of parents and professionals who are working together to help our children thrive. This is a parent-led organization, and it's very much a parent-focused Preemie Chats as well. So we would love for you to let us know where you're joining us from in the comments. Feel free to share your thoughts as we go through today's presentation. We'd love to know where you're joining from, what brings you here. Today's presentation will be focused on preemies and pulmonary hypertension. We have 3 guests who will join us today for this discussion. Dr. Gabrielle LT will start our talk today, reviewing the condition, its risk factors, methods of detection, and strategies for management. Then we're going to be joined by one of his patient families. Priyanka and Anthony are the parents of 3-year-old Massimo. They're going to share a bit about their journey, touching on the challenges that are faced through diagnosis, discharge, and development. Dr. LT is a neonatologist at McGill University and Montreal Children's Hospital. He's the creator of the Neocardio Lab at McGill University Health Center Research Institutes, and he launched the Hemodynamics Clinical Research Fellowship at McGill. He's also a regular here on Preemie Chats. Welcome back, Dr. LT.
Thank you so much, Jenna. It's such a pleasure to be here and to be able to actually share the stage with Anthony and Priyanka today, which I think is going to be the most meaningful part of the talk for everyone on the line today. So I'm very looking forward to hear their story and for them to be able to share their journey with Massimo. And you know, I think a lot of people will relate either as a healthcare professional or as a family or as an extended member of a family that went through the NICU. So I'm very grateful that they accepted to join us today.
So am I. I've had a chance to speak a little bit with them, and I know it's going to be really powerful when we get to that part. But before we dive into that, I know you have a presentation prepared to give us some background and some medical context to this. So I'm going to turn the floor over to you.
Thank you. So I'm going to share my slides now and share my screen. My hope today is to discuss a bit on the chronic pulmonary hypertension phenotype that is associated with prematurity. And so, as Jenna mentioned, I'm one of the neonatologists at the Montreal Children's Hospital and the McGill University Health Center. And it's really a privilege today to speak about this topic. I have no disclosures to make relative to this presentation. And today we'll dive a bit into what is pulmonary hypertension, why are patients with prematurity, and specifically those with some degree of lung disease related to prematurity, will develop this pulmonary vascular disease, or what we call this pulmonary hypertension or high blood pressure in the lungs. And we'll talk about a bit, you know, the context of the heart in the context of pulmonary hypertension, and a bit of what's my approach to some of these patients that end up with this diagnosis. So what is pulmonary hypertension? Let's start with the basics. Well, the same way you speak about high blood pressure when you go to the pharmacy and you get your pressure measured in your arm, and your pharmacist or your doctor or your nurse will tell you, well, you have high blood pressure. This means that you have high blood pressure in the vessels of your system. Some people may develop high blood pressure in the vessels that are reaching those lungs, typically what we call the pulmonary artery. And so in order to be able to understand how to tackle this, you need to be able to understand the underlying process that is happening. So for example, this abnormally high blood pressure in the pulmonary artery can be a symptom of many processes, one of them being something called bronchopulmonary dysplasia, which is a disease of the lungs associated with prematurity. And so once you have identified the condition, or sometimes the multiple condition that may occur at the same time, you're able to tackle and tailor your treatment. Now, we often use certain cutoffs of numbers when we're practicing medicine to be able to establish the normal from the abnormal. And sometimes these cutoffs, and most often these cutoffs, are based from whatever research we've been accumulating on some of the population of patients we're treating. And so currently, most of the guidelines that we have underhand have established a cutoff of 20 millimeters of mercury in terms of the mean pulmonary arterial pressure as a value that signals that there is high blood pressure in the lungs after the age of 3 months of life. Why after the age of 3 months of life? The reason is that the first 3 months are associated with a progressive change in the vessel caliber of the lungs from a fetal state to a postnatal state. So fetuses have lungs that are completely compressed, and all these vessels in the lungs are very, very tight. And after birth, typically babies will open their lungs like parachutes, and all of these vessels will become completely open and will be exposed to oxygen from the ambient air, which is a potent vasodilator. It makes these vessels relaxed. But you can think how this process, although exponential, may take some time, up to 3 months of life to happen to its fullest, but it also may be affected by some conditions like lung inflammation, prematurity, infections, and various other types of lung disease processes, which may cause injury to these vessels and also may alter this trajectory. However, babies with prematurity will often reach the age of around 3 months of life at the time of what we call 36 weeks corrected. 36 weeks corrected age is often the timing upon which, as clinician at bedside, we establish if there's some degree of residual lung disease, as exemplified by the need for oxygen or respiratory support. And so it is at that time point that most often we evaluate if these patients with some degree of lung disease may have underlying degree of vascular disease, which may be leading to high blood pressure in these lungs. And so while we can use a catheter in the cath lab to go inside the pulmonary artery and measure the pressure, this is quite invasive. So for most patients, we actually use ultrasound, which is non-invasive, and we often call it an echocardiography in the context of ultrasound of the heart, in order to be able to estimate something called the systolic blood pressure in the lungs. And cutoffs around 40 millimeters of mercury of systolic pulmonary arterial pressure are felt to represent values of mean pulmonary arterial pressure that are in the higher range and beyond 20 millimeters of mercury. So there are definitions of whether this high blood pressure is secondary to a problem in the arteries versus a problem in the veins. Problems in the veins would cause blockage of the drainage of the lung and may reflect as high blood pressure in the artery. However, these two conditions may not be completely addressed the same way. And so sometimes at the bedside and as clinicians, we need to figure out what is the underlying problem. Is it a question of the artery being the problem? Is it a question of the veins or the drainage being the problem? Or is it a question of a mixed picture? And so you may wonder, why are premature infants at risk of this high blood pressure in the lung? Well, this is a classification of pediatric pulmonary vascular disease, pulmonary vessel disease. And you can see that the lung disease of prematurity, or bronchopulmonary dysplasia, is considered to be its own category of causes of pulmonary hypertension. And the reason is that it's a really multifactorial effect. Well, we know that babies who are born premature are exposing their immature lungs to oxygen, which can be sometimes toxic, to trauma to the lungs due to mechanical ventilation, We know that they have immature repair mechanisms, and sometimes that can lead to scarring of the lungs in different areas of the lungs. So this might not be something that's uniform. It could be patchy or heterogeneous. There could be inflammatory stressors like infection or ventilation. And we know that the nutrition in some of these patients may not be optimal because they don't tolerate enteral nutrition, or because the amount of nutrition that we would like to give them is not as optimized as they would get otherwise in utero during fetal life. Many of these patients may have other types of predisposition. They may be exposed to a fetal environment that had some stressors as well, or there might be some genetic predisposition to make these vessels a bit more fragile. And then finally, a lot of the interventions that we do to help babies may sometimes have side effects in terms of disturbed vascular growth. So within the patients with prematurity and some degree of lung disease, we know from studies that they have abnormal vasculature, both in terms of that growth and remodeling, where they get more muscle buildup around these vessels. We know also that they get less surface area. There's less amount of vessels because the lung got injured. And also we know that there's this heterogeneous effect where various areas of the lungs are actually not exactly the same way for both the airways, the lung itself, parenchyma, and the underlying vessels. But one thing we do know is that many of our babies that are born with prematurity are full of resilience, and they're full of surprises, and they grow and they often get better, and they show us that they have an immense capacity to recover from some of these various processes that may cause some degree of injury to their lungs. And so typically, as the lungs are getting better for most patients, the vessels are also getting better. So some of the risk factors for this condition include being born very premature, being born in the context of growth restriction, having less fluid during the end of the pregnancy, which we know is something that mechanically helps the lungs to grow. We know that after birth, if they're exposed for a longer time on ventilation, this may outline that those lungs are a bit more inflamed, or if they have other types of inflammatory stressors, they may develop some degree of vascular disease. And the problem is that having high blood pressure in the lungs can end up leading to very severe impact on the heart. Why? Because the heart is trying to push blood inside those vessels. And if these vessels are exposed to a very high blood pressure, well, this heart may have difficulty pumping blood inside those lungs, and eventually it may fail. And right ventricular failure, which is the side of the heart that is exposed to the blood vessels in the lungs, can be associated with a significant portion of patients who develop lung disease in prematurity. And the problem is that many of these patients are at risk of mortality because of this heart failure. And it's only recently that we recognize how much having high blood pressure in the lungs was kind of a silent disease and needed to be addressed to try to improve this mortality and these morbidities associated with this condition. The complexity of it is that, as I just mentioned, it's a heterogeneous disease. It comes with various areas of the lung having various types of conditions like arterial problems and venous problems, and also compounded with the underlying lung disease, which has airway and parenchymal problem. As mentioned, we often use echocardiography at the time of the diagnosis of lung disease of prematurity, and these are the American Heart Association and American Thoracic Society guidelines on pulmonary hypertension, as well as the group of the Pediatric Pulmonary Hypertension Network who recommended for screening using echocardiography. And so that's why at the Montreal Children's Hospital, as well as in collaboration with the centers in Quebec, which are under the Targeted Neonatal Echo Collaborative, we've established a provincial approach to screen these patients if they do have signs of chronic lung disease at 36 weeks, and also with an algorithm to be able to tackle the treatment in a uniform way in collaboration, in collaboration with our team of respirologists and cardiologists, because this is a multidisciplinary approach. So when you're using echocardiography, our protocol is obviously we would love to have values of what we call mean pulmonary arterial pressure, A blood pressure has three components, typically a systolic phase, which is the peak pressure, a diastolic phase, which is the pressure that remains in the vessels after the heart contracts, and then an average of all of these values. And so we would love to be able to measure the average, but it's often quite difficult by echocardiography to do that. We may be able to get a sense of that by measuring something called the pulmonary insufficiency, but we often get more values of that peak pressure, the systolic pressure, using what we call the tricuspid regurgitant jet, or using shunts that may be able to appreciate the relationship between what's happening on the systemic side compared to what's happening on the pulmonary side. Otherwise, if we don't have these quantitative measures, we'll often use other indirect measures, such as the way that the heart behaves between the left ventricle and the right ventricle, where these two ventricles are interacting together. And typically, the left side, which pumps into the aorta, is supposed to be big and round, and the right side, which is supposed to push blood inside this lungs, which is supposed to have low blood pressure, is supposed to be very slim and crescentic, which in this case you can see that there's almost flattening of that little septum that they share together. And so we can use various ways to quantify this deformation. This is an example of a baby who has a completely normal left ventricle compared to the right ventricle versus someone who has an RV that's exposed to very high blood pressure in the lungs. But many times it's not straightforward. You may have shunts, you may have difficult images, you may have the left heart that has a problem. Many of these patients have to undergo comprehensive assessment and see the evolution and have a multidisciplinary team, including cardiology, radiology, ENT, and respirology, as well as allied healthcare professionals like occupational therapists and nutritionists, nurses and respiratory therapists, and other members of the team to help tackle how to best approach these patients. Quickly, this is one of the publications of a population of patients who had pulmonary hypertension, and you can see that some of them developed vein problems, but you can also see that a lot of these patients at the time had increased risk of mortality when they were diagnosed with pulmonary hypertension, and that many of them actually required medications to help their heart actually improve. What about this heart performance? Well, there is recommendation of many ways of assessing the heart. This is one of the tables of the paper from the Pediatric Pulmonary Hypertension Network, which has a comprehensive list of how we should evaluate some of the right ventricular function and left ventricular function. And some of the measures that we do are obviously related to the size of the heart and the behavior of the heart during its contraction, as well as how much this right ventricle is vigorous in terms of going up and down during the contraction. Why is this important? One of the population that we studied with pulmonary hypertension, we actually found that at diagnosis, the right ventricular function was the element that was the most predictive of having mortality outcome. The severity has been established as when you have sign of already right ventricular failure or right ventricular dysfunction, you have a severe profile. So you can see a patient here who have very, very high pressure, very dilated right ventricle, both on the top view, which is a parasternal short axis, and from the side view where you see this RV much bigger than the LV. And so for your reference, I've put here the scheme that we use to classify the severity on assessment based on mild, moderate, and severe, which helps us guide the way we're going to treat these patients in the clinical practice. And all of this is available on the NeoCardiolab website if you're looking for references. We do think that it's very important to assess comprehensively the heart of these patients as well as the lungs of these patients. And part of this comprehensive assessment is to also assess the venous drainage, because I mentioned that some of these babies may develop pulmonary vein stenosis. And so what's the role of the left side? Well, we know that all of these injuries to the lungs that may affect those vessels in the right heart may also affect the left heart. Some of these patients may also develop what we call systemic hypertension. And so really we need to look at all of this in order to provide a comprehensive treatment to some of these patients. They may have problem with contraction of the left heart, but may also have problem with relaxation of the left heart, which may cause problem to the drainage of these lungs. And so these are all of the many reasons that are the same reason that we often see problems to the right heart and the lungs that may also affect the left side of the heart. There's great publication actually outlining why could there be that some of these patients develop drainage issue to their lungs. Well, we think that some of it may be inflammation or scarring, some of it may be genetics, but usually this happens at a later course in life in some of these patients. And the problem is that we need to have a very high degree of suspicion, especially in those who have lung edema, worsening on some of the treatments that we may implement, or some of these babies may also have arterial component to their disease. And these are the specific patients we may need to do some more advanced modality of testing like CT scan, cath, or MRI. So what should we do for these patients? Well, first, prevention is obviously key. Typically, if there's no BPD, there's no pulmonary hypertension. And typically, pH usually reflects the lung disease, but it's not always true. You will see patients with milder forms of BPD who end up with some degree of pulmonary vascular disease. But in general, you want to make sure that your team has a comprehensive pathway to treat or to prevent BPD with good airway and CPAP care, a protocolized approach to the management of patients with prematurity, as well as a multidisciplinary approach to these patients once they do develop the phenotype of pulmonary hypertension. So because pH comes from a multifactorial setting, typically most guidelines will recommend to avoid low level of oxygen in these patients, because if you start having dips in your saturation, you may cause remodeling to these vessels with progressive vasoconstriction of the vessel, which may not be good in terms of recovery of these vessels. We need to optimize the nutrition while avoiding reflux and aspiration, which may continue to injure these lungs and create inflammation. And finally, having ENT evaluate these airways may help you better understand if there's air trapping or CO2 retention, which may also affect to some degree the pulmonary vasculature. Typically, guidelines have recommended for saturation above 92%, multidisciplinary care, and avoidance of hypoxemia. Obviously, vaccination is important to avoid pulmonary infections for both the newborn, but also the family, to avoid bringing viruses at home and leading to inflammation stressors. We spoke about reflux and aspiration, but it's very important to maximize the nutrition while still avoiding having disproportionate growth. It's important that these patients grow optimally according to their growth curve. Once you have a diagnosis of pulmonary hypertension, often the team will send adjunct tests. Examples are electrocardiogram, blood gas to assess the CO2 clearance, the presence of anemia, making sure there's no problem with the thyroid, and have at least a baseline radiography for some of these patients. Although the evidence is weak, there is some evidence to show that some of these patients, especially those with some degree of pulmonary edema, may have a response to a low dose, very short course of diuretics. Now, this is not based from trials, but our approach has been if there is a diagnosis of moderate to severe PH, we do start them on some low dose diuretics and follow for response. And if there is a response, we maintain for a bit of time this medication. And if there's no response on echo or clinically, we do end up stopping this medication. These patients, as mentioned, may have comorbidities of lung and airway disease, so it's important to tackle them as a team. If the RV function is stable, we typically will give some time to these lungs to improve while following these patients using echo. We try to avoid stressors like elective surgery, but if they do need a surgery, we try to involve our an anesthesia team who's the most experienced in managing pulmonary hypertension to avoid developing what we call these pulmonary hypertension crises, where all these vessels will constrict at once and cause severe issue to the heart. We involved our ear, nose, throat team to rule out some of the anomalies of the airway and some of the obstruction to prevent significant CO2 retention. And we do try to maximize the ventilation, hopefully non-invasively with CPAP or non-invasive mechanical ventilation. Sometimes these patients do require to go back on some degree of invasive ventilation to optimize their ventilatory status. Some of these patients may need CT chest or MRI if there is a concern of venous drainage. And obviously, parents are key partners into all of this. So parents need to be involved right from the get-go to receive information about how to recognize signs of respiratory distress, right ventricular failure, such as, for example, signs where their child might be sweaty, diaphoresis as a sign of distress, or having retraction from difficulty breathing or increasing work of breathing, being blue or being gray because the heart is not behaving normally, or having adverse neurological status where suddenly the overall status is deteriorating. Some of our patients actually undergo basic cardiopulmonary resuscitation learning modules in order to be able to provide immediate assistance in the community if there are concerns for some of these patients. I've put here a reference of how we approach our patient with mild, moderate, and severe pulmonary hypertension in order to gear the follow-up frequency. And so this will be available through the slides. And then some of these patients may end up getting this catheter-based evaluation, which is an evaluation where we put a catheter in a vein and we go into the heart and we try to measure directly the pressure and better understand what's happening. Now, this does not happen very frequently, and it really happens in some of the selected patients in which we have great concerns about what's happening for the pulmonary vasculature. And so it's typically done in after a team meeting in multidisciplinary fashion, and obviously consultation with cardiology and NICU and anesthesia in order to decide if we need to confirm the pulmonary hypertension, but also test in the cath lab if some of the medications that we have are responsive in terms of improving the degree of pulmonary hypertension while doing the measurements. And some of the reason why we do a cardiac cath locally at our institution would be if there's a concern of pulmonary vein stenosis, if we think there's some communications in the heart or outside of the heart that may contribute to the disease of these vessels, if our patients are worsening or not improving despite the ongoing treatments that we're giving, or if we see that this pulmonary hypertension is so severe that it's considered to be higher than the blood pressure in the system, in the aorta, which is not supposed to be the case. And then finally, one of the other concerns that we sometimes need to rule out are some of the left-sided heart defects or disease that I mentioned, where the treatment might be a bit different. We do consider some medications that are called pulmonary vasodilators. These are medications that tend to decrease the tone of the vessels in the lungs to try to decrease the blood pressure. Now, these medications have been mostly tested in more adult populations and pediatric adolescent population. But if we need to sometimes rescue the heart, we will give some of these medications to try to decrease the pressure in the lungs. And typically we'll do that after we've optimized the respiratory status and in conjunction with expert teams. We have sildenafil, which is typically our first line, but we do have caveats here where it may worsen this ventilation perfusion mismatch in those lungs that are heterogeneously affected. We also consider other types of drugs like prostacyclin and endothelin receptor antagonists, but this is beyond the scope of this presentation. I've put here as a reference some of the medications that are currently commercially available, but I do want to remind everyone that these have not been formally tested in the context of trials for pulmonary hypertension and BPD. And so if there is the decision to treat some of these patients, it should be done in collaboration of a team of experts in this particular patient population. I did put here a QR code to my website, which has a lot of resources on pulmonary hypertension, a lot of learning modules. You can also access the app by downloading on the App Store or Google Play by searching NeoCardiolab, and it also has a family section. So in conclusion, premature babies who develop lung disease are at risk of developing vascular disease to the lung and pulmonary hypertension. And so that's why screening has been advocated, considering that it often has a silent clinical nature. And so picking it up before there's actually symptoms of cardiac failure may help us introduce therapies to really promote a better recovery. We know that there's multiple etiologies or causes that are unique to the lung disease of prematurity, like pulmonary venous return, venous drainage, underlying heart conditions, and increased pulmonary vascular resistances. We know that having pulmonary hypertension can increase your risk for mortality, and that the outcomes are influenced by the underlying cardiac performance. And so that's why it's important to detect this patient early to potentially alter this trajectory towards a more optimal trajectory. And we are concerned that there might be some patients who develop some lifelong conditions. And so by starting early and detecting early, we're hopeful to bring them to adulthood healthy and free of disease. And so future research involved prevention, finding more early markers, getting more information about targeted management, refining the diagnosis and management pathways. But I do want to bring, and that's going to be the next part, the perspective of the parents, because I do think it's very important to understand what's meaningful for parents and families in terms of improving the care that we do and allowing us to better improve the pathways that we develop and that we research specifically in the space of pulmonary hypertension with prematurity. So thank you so much for inviting me. And on this note, I'm going to stop sharing my screen. And I'm going to invite Priyanka and Anthony, who are my patient partners. I've met Priyanka and Anthony from the first few days that they came to our NICU. And then I met Massimo, who's now a beautiful, healthy boy, running around, full of energy. But I would love to hear more about their journey and their story, and for them to share a bit of the journey of pulmonary hypertension and how it affected their own life journey. So Anthony, Priyanka, thank you so much for sharing your time and for allowing us to hear more about Massimo and what you went through during the first year of Massimo's life. So my first question would be, tell us more. Tell us your story.
I'll let you start.
So thank you, Dr. Alti. So definitely the first thought when we were discharged from the NICU is we thought maybe we had passed the hurdle and now it's just checkups and just let Massimo grow. When we had a follow-up heart echo 3 months post-discharge, and it was communicated to us that he had severe pulmonary hypertension, it definitely came as a shock. Also, it's not something that we're familiar with. It's not something that a disease, that we're familiar with or kind of heard of. So definitely just trying to understand what are the implications, what does this mean to Massimo, what's the treatment, if he could develop normally with the treatment, were all kind of initial concerns and scares, and that was kind of the first thing I think racing through both our minds.
So I'm just going to backtrack a little bit, just to add a little bit more context. So Maximo was born in 24 weeks. Dr. Alti obviously approached us and he said that he's doing this research. We didn't really understand, but we're like, sure, we're going to participate in the research. So I guess it kind of ended up saving Massimo's life, long story short. So when they first did his heart echo, they realized that he had mild hypertension. They got the cardiology team involved. Nobody was concerned because, again, it was really mild. So you know how you were mentioning the number, the 40, and I think it was just like 41, 42.
It was like borderline. It was borderline.
Borderline. So I remember one of the doctors came in. I had a lot of questions because I did not understand what hypertension meant, right? So one of their nurse practitioners, she was really kind. She did a whole drawing. She explained it to me perfect. And then the doctor came in. They're like, there's nothing to worry about. So already you have so many issues to face. This was in the back of my mind. Nothing to be worried about. Follow up in 3 months. And that's where Anthony's story continues. Post 3 months, it ended up being mild to severe. So I don't really have anything else to add on to that besides for the fact that it was complete shock. Did not understand what's going on because we went from mild to severe and nobody, correct me if I'm wrong, Dr. LT, but I don't think anybody predicted this happening. Like it was a shock to a lot of the medical professionals, including ourselves. And our child he did not show any symptoms. So yeah, we can go back all we want. We can be like, well, did he look sweaty? Did he look tired? Did he? we'll never know. Like it could have been, it was summer days, it could have been the sun. So we just, he was eating normally, he was behaving normally, he was laughing, and suddenly it's oh well, if you guys were a few weeks late, he'd be part of the
heart would have
the heart failure, right?
Heart
failure. So that's what I wanted to add.
To add to kind of the surprise, also it's a shock to the medical team that he went home. Like this could happen to him, and he went home with no oxygen. He went home. He didn't appear to have reflux. So I guess it just goes to show that it really is a kind of a silent threat and a silent killer. And so that was our first reaction.
Yeah, and well, first of all, thank you for sharing that, and thank you for participating to research, right? Because I think at the time when we were doing this research project, we were trying to better understand who are babies who develop like some degree of lung disease or some degree of vascular disease. And really, you know, we were still in the phase of implementing more of that screening program because the guidelines had just been published, right? And you agreed to participate to a research project out of like pure generosity of saying, you know what, like, let's do it just if it helps others, like why not, you know? And it ended up giving us the opportunity to help others at such a bigger scale, right? Because now we can tell the story of Massimo as a success story in the sense that we picked up something very early. We were able to track you after the fact. And I think we picked up something that as a clinician and researcher, of course, we didn't expect, because as you mentioned, you know, Massimo had airway disease, but overall had a trajectory that, you know, went home, as you said, in room air, breathing, you know, and eating and growing and behaving. And I don't want to make people on the line panic, like, oh my God, maybe my kid has pulmonary hypertension. But I think nowadays what has changed, because things change so quickly, is that I think I just outlined that locally, all of our patients are going through now a systematic approach. And that's pretty much something that we do at the scale of the country now. So it's not unusual anymore to screen babies and to try to find these signs of mild struggle. So now that we had this data that's been accumulating and we understand a bit more, the patients who do end up with even some degree of lung disease, we actually screen for the fact that could there be underlying signs that there's some RV, you know, cardiac struggle or pulmonary hypertension. So we're able to tailor the follow-up for such a new generation of premature babies. And I must say that, you know, a lot of your implications and research and also in the clinical space helped many of our families, because, you know, we've had other patients, and that's where I want to talk about my second question is, like, you were obviously taken aback, and I think what's important for us as a community is to find ways to better support you or support future parents. And so the questions are, how can we be better at supporting parents when they do go through this, and giving them the hope and telling them the stories like Massimo, who did go through all of these hurdles and now is like a beautiful, growing, healthy boy full of potential, free of any kind of treatments. And, you know, what are these strategies, like trying to create partners or patient mentorships or even inside of hospital mentorships? So would love to hear more about your experience on that, and what is your perspective on how can we be better in that space to support some of our families?
Perfect. I think you hit the nail with the parent mentorship, and like you had like while we were going through it and kind of getting close to discharge and going home, I know you had connected us with parents that were kind of in the preliminary stages or kind of just discovering that their child had pulmonary hypertension, and I think that helped the other parent to kind of hear it from, you know, maybe in layman's terms, or kind of what another parent is going through, and that there is a hope to the kid will can still develop normally and still kind of be a child, and kind of you know, you can get through this. Actually, perusing the CPB's website, I noticed that they do have that. I think that option for connect parents. So I think that's probably a good resource to use. And I guess the other thing that came to mind is kind of treat this like you would get any other diagnosis. Kind of like, this is your new reality, and we're gonna kind of do our best, and we're all going to become Massimo's nurses. And he had to not only take sildenafil and bosartan, but treprostinil, which is given subcutaneously. So we had never touched a needle before. We had to learn how to fill the cartridge and manage manage machine, manage the site, look for the signs. So and we had to kind of come to that realization really quickly if we want to kind of get him the best healthcare at home, and then also make sure that we don't let him miss out on any kind of childhood development. So it was definitely a balancing act that was not easy.
I would tell parents, don't Google.
Don't Google, yes.
Don't Google. Just reach out to the nurses, the medical professionals that are there, because that's going to be your right source of information. I Googled, it was horrible. My husband couldn't believe it. I remember Dr. LT, you're like, don't Google it. So as a parent, I'm going to pass on that information. Don't Google. Just reach out. To me, information was key. I needed to understand what was going on. I do remember some of the nurses will share stories about other kids that kind of are going through this or did go through this, and they didn't share the pictures, but they kind of described. They're like, well, I see them. They're living their perfect. They're just being kids, and that was really reassuring to me. So there's going to be the whole medical background, medical knowledge that you do want, but you also want the information from other parents that, look, it's not stopping my kid from going to school. It's not stopping my kid from playing in the park. It's not stopping my kid from having friends. I think we need to normalize it. I understand it's a new normal, but let's not call it that necessarily. It's a different, right? Mm-hmm. So every kid is different in its own way. And
like, what is normal, right?
So just treat it as he's just different. But who isn't different? You and I are different. Him and I are different, right? So I think to us, it just matters, is he going to have friends? Is he going to be able to go to school? Is he going to be able to, if he aspires to be I don't know, a doctor, can he become a doctor? Like, so focusing on that, I think that will be key. That's my opinion. So,
I think, your story is also like the power of how much the love of the parents and the support of the parents and the structure that you gave and everything you invested in having, you give a medicine to Massimo that no doctors or nurses can give. And of course, you give us the privilege of entering your intimate kind of sphere of life to help you guys help Massimo. But at the end of the day, what you've done and what you do to support the growth and help Massimo get to this healthy stage is unique. It reminds us as physicians the power of love and the power of having this family structure that's so important. And so congrats on that. You're very inspirational as parents for that. And we meet so many parents, and I'm always amazed on, the love and the dedication and how much they bring as part of the therapy. They're the main treatment, I think. And for our premature infants, we know that, they continue to surprise us of how much power they hold in themselves to grow, and they're little champions going through each little, challenges and each little wars that they confront and really winning them one after the other, right? Which brings me to the aspect that, you mentioned treprostinil, you mentioned medications. I think Massimo was a fair bit of time on all of these, and I think nowadays he's on none of these medications. So talk to us about Massimo today. How is he doing?
Oh, well, I mean, his pediatrician is happy. He's normal 3-year-old. He's actually even at a good percentile for his actual age. So not even even though he was born 3.5 months early, he's kind of at a healthy weight and height and development for his actual age, which is very happy, and he's chatting and
but curious. We're also very, very fortunate that we were able to spend as much time as we could with him, right? So we asked what's going to help him. There's not much we can contribute, and they said keep him away from viruses. So that was our goal. That was the only thing we can do, right? So we kind of sheltered our lives. We stopped living. We didn't see any friends, and we just kept him home. But we're also very, very fortunate that we had the right support system. Our companies allowed us to that flexibility, that understanding. So I think that really did play a factor in how Massimo is doing now. But yes, to add on to Anthony, he's speaking 2 languages. He doesn't stop talking, which is great. He has a very big love for zoo animals. So rhinoceros, alligators, and butterflies. That's his thing. But no, honestly, like we're trying to. Sorry for using that word. We're trying to normalize his childhood, or trying to introduce him to other kids, to start play dates. Because then again, it came at a price, right? When you shelter a kid too much, he doesn't know how to interact with other kids. He doesn't, like, he's great at socializing with adults because that's all what he's seen. But introduce another kid and he doesn't get it. He's like, what is this other human doing here? So we're trying to introduce that slowly. We're thinking of next steps, what to do. Is it going to be pre-K? There's still going to be a balancing act. There's still going to, he still needs improvement. He doesn't know how to use scissors, but then he can tell you his ABC. He has his things that he can do, because as adults, we were able to provide it. He can sit down and have a conversation with an adult, but he can't draw he can't color. So we're just managing it all, and we're trying to figure out. But I'm hoping when he's 12 years old, it's going to be all behind us, and he's going to be able to write his name.
We have about 10 minutes left to the discussion, and going back to the aspect of pulmonary hypertension, you did mention something that was very striking, and I think it's all our roles as healthcare professional. Support to families, nurses, doctors, pediatrician, the aunt, the sister, the uncle. We should all be aware of the fact that many families go through prematurity, and then if they do end up with a situation of pulmonary hypertension and the concerns that come with it, with the aspect of the guilt. We don't talk about it that much, but you mentioned something like, I kept on going back and I kept on not seeing all of these, there was no symptoms. And meanwhile, I'm being told that there's this severe pulmonary hypertension, there's this severe lung disease that may cause his heart to have a lot of issues, and we need to treat it. I think that's, for me, a key message that I need to do a better job at explaining to families, that when we have that, there's nothing that they could have done or not done, number one. This is something that, some babies develop, and that's why we're doing research to try to better understand why, who, when, how to be better at preventing it and better at treating it. But number two, that's why we call it a silent disease or a silent killer. I hate that word killer, because now we're trying to not make a killer. We're trying to figure it out that it happens before it gets to that stage. But it's being called a silent killer because until the moment that you collapse, many of these people don't have symptoms. And that's why we screen for it. That's why we do an echo. That's why we're trying to be vigilant. That's why we try to put all these safeguards to avoid getting to that rare portion of patients, but still present, that do develop this kind of phenotype of these lung disease. So I'd love to hear about this, as you reflect back on the silent nature of this condition, and what did you feel immediately and after the fact, the next few weeks and next few months, as everything unfolded, about what people told you, or how, what's your reflection on all of this, like the silent aspect of the disease, and hopefully the message that there's nothing you could have done to prevent it or to recognize it, and that's why you had the appointment, to make sure that we detect it.
So I'm gonna add on to your guilt comment. I feel guilty from the time that he was born, right? Because he was born prematurely. So
which is nothing you can control, right?
It wasn't, honestly, it wasn't, but it's always going to be in the back of my mind. What if I went to the Montreal Children's, Montreal Hospital? What if I didn't go elsewhere? What if, right? So the guilt it started from day one. So I think that kind of consumed me. When we got the diagnosis of severe pulmonary hypertension, yes, the guilt is always going to be there because maybe we should have seen something before. But then at the same time, I didn't feel as guilty because we did go through the right channels. We did have the echo. We did there was a study, there was a follow-up part echo. We showed up on the appointment. If we didn't show up at the appointment, then the guilt will have been magnified. But we were there on time. So I think it's because my guilt was overconsumed from the time that he was born that it didn't get to that point when we got the severe pulmonary hypertension diagnosis. But I did feel, why this again? I can't believe it. We're back in the hospital after spending 6 months. I thought we were done with it. So it was more like, why me? Why him? What's going to be? What's our story now? Like, it's so unpredictable. So it was a lot of the unknown, a lot of the, what are we doing back here? I can't believe it. We can't be in the comfort of our house. So it was more of that. And we were just terrified. Like, I remember my husband asking, is his life in danger? Like, is he going to live through this? Right. Like that was our main question. So it was a lot of those mixed emotions of like, we don't know where we're going with this. Is he going to live through this? How is our next few months going to look like? What else his life has in store for us? And it was more of, why did this happen to us? So that was my feeling at that point. I felt the same way. Okay. Do you?
Well, absolutely. I'm going to reiterate how you represent all the parents that we see. And that's the first thing I tell them when I meet them in consult, when they're at risk of delivering premature. I tell them, there's nothing you've done or not done. You're like amazing parents. And it's just, nature puts us challenges. It's like you arrive at the red light, it turned green, you crossed, and then there's a car that hit you. Like you followed all the rules, you followed everything that you were supposed to follow, and it happens. But the positive is that today, Massimo is healthy and growing. And despite all of these challenges, was surrounded by love and surrounded by amazing family and parents that provided him with all of the amazing opportunities to make him as unique as he is. And that's just, for me, a lesson to be learned, because I think every story we go through the NICU, there are all of these beautiful stories. There are all of these beautiful, unique sparks of life and of hope. And regardless of the trajectory, they're all very unique and they're all very inspiring. So Priyanka, Anthony, thank you so much for being such an open book, for allowing us to get a better sense of, how Massimo is amazing and how you are amazing parents.
Thank you. Very kind.
Oh yeah, and then I'm sure that everyone on the line has been very touched by your story and how, you've been so dedicated to the health and the growth and the happiness of your son, and you're going to inspire many people, I think, to participate to research today. So that's also a very big plus, because I'm a researcher, so I have this bias.
Yes, I want to thank all three of you for sharing so openly and taking so much time with us. And to Dr. LT's point, I think it is the most important message for everyone to remember, is that things just happen. We can't control what happens. We control how we react and what we do after the fact. And you having the strength to come on and share so openly with us today is going to be a huge help for so many people who are watching, whether they're watching now or, years from now when they find this video, because they're going through something similar. So thank you so much for your time.
Our pleasure.
Thank you so much. Thank you.
And thank you, Dr. LT. And I know you're going to be back here on Wednesday. We've got a special scientific Preemie chat coming up, talking about patent ductus aeratosus management in infants born less than. Yeah, I'm not the one for medical terms, although I recognize some of those from my own journeys. So I'll be tuning in as well. And thank you, and we'll see you here again soon.
Thank you so much for the invite, and that was that was a wonderful talk. I really enjoyed it. Thank you.
Thank you. And I want to thank everyone who was watching and sharing in the comments and who's going to be watching this after the fact. Please, if you know someone that you think might benefit from watching this, you can find it on our YouTube channel. You can find it online. The best place to go, of course, is our website with it, which is canadianpreemies.org. I'll put that up on the screen there again for you. And I just want to take a quick moment to thank our sponsor, AstraZeneca, for their ongoing support of our educational programs, as well as our partners at the Canadian Association of Neonatal Nurses and our partners at PhiCare. Of course, Preemie Chats happens here every Friday at 1 p.m. Eastern. I hope that you're able to join us again, as well as for the special Preemie Chats that's coming up, the scientific edition. Thank you so much, and until then, take care.